The differential diagnosis of distributive shock includes septic shock due to overwhelming infection, anaphylactic shock in the setting of a severe allergic reaction, and neurogenic shock in the setting of a central nervous system injury. Isolated toxic shock is not terribly common, but it is related to toxins released by staph and strep bacteria. It was first described in tampon users, where the bacteria grew on the blood-soaked tampons. It can be seen in conjunction with other strep and staph infections, usually alongside septic shock. Adrenal insufficiency can also lead to distributive shock. From the above, it becomes pretty clear that the history is very good at identifying patients in distributive shock, which should be considered in patients in shock presenting with infection, spinal cord injury, known adrenal insufficiency, or long-term corticosteroid use. The physical examination in distributive shock reflects the underlying pathophysiology. Decreased afterload results in an increased cardiac output, though regulation of that blood flow is problematic. Patients are often warm, and their precordial impulse is often bounding. A rash can be seen in anaphylactic and toxic shock. Usually anaphylactic shock is accompanied by upper airway swelling and wheezing. In addition to the standard labs, patients in distributive shock, particularly those with septic shock, should have cultures drawn along with a urinalysis. If adrenal insufficiency is suspected, a serum cortisol might be helpful. Imaging may be helpful in determining a source of infection. Chest X-ray is standard, but CT scanning or ultrasound may be necessary.